Hello, everyone. My name is Amitis Medifar. Today, I'll be sharing highlights from my practicum, which focuses on health inequities in the Southeast region in Ontario using a tool called Shared Health Equity Dashboard, or SHED. Before I begin, however, I want to acknowledge that I live, work, and study on the traditional lands of Anishinaabe, Haudenosaunee, and Huron-Wendat people in Kingston. I'm grateful to be here and committed to ongoing reflection and reconciliation. So here's what I want to walk you through today. First, I'll give you a quick overview of my practicum project and the health equity profile I developed. And I will dive into some of the key gaps and inequities that showed up when I looked at the data from the Shared Health Equity Dashboard. So let me start with the purpose behind this work and why I created the profile in the first place. So the goal was to take complex data and make it more accessible and usable for public health staff at the agency I worked at. So this was very much a knowledge translation project. At its core, the profile was created to raise awareness about where health inequities exist and for whom in the Southeast region. These patterns aren't always visible and obvious when we look at overall population stats, but tools like SHED help bring them to the surface. Excuse me. I chose to focus on indicators where disparities were statistically significant, especially those where gaps in the Southeast were wider than in Ontario overall. The intention was to spark internal dialogue in the agency, spark reflection, and ideally more equity-focused decision-making, whether that was in planning, programming, or policy work. So what is SHED? SHED stands for Shared Health Equity Dashboard, and it's a data visualization tool and was created by the knowledge management team through a collaboration between three legacy health units in southeastern Ontario. What makes SHED unique and different from other tools out there is that first, it's fully web-based and interactive, which means users can explore different indicators and compare groups directly within the platform. It is also designed from the ground up with equity in mind. That means the focus isn't just on overall population averages, it's on identifying where the biggest gaps are and who they affect. One of the most useful features is that it shows both the magnitude and the statistical significance of each gap. So we're not just looking at whether a difference exists. We can actually see how big it is and whether it matters from a statistical standpoint. This makes SHED a really valuable tool for identifying where to focus resources and interventions. So let me show you what it actually looks like. So this is SHED in action. What you're seeing here is a typical SHED view. It's built to be interactive, so users can filter by topic areas over here, like physical activity, mental health, and then choose stratifiers from a drop-down menu. And those are like education, income, sex. And the center of this screen shows a bar graph that compares health outcomes across different groups. And on the right, SHED gives you two key tools for analysis, rate ratio and the rate differences. One of them, SHED's standout feature is that ability to highlight a statistically significant differences using these red boxes you see here. So that helps user quickly spot where health gaps are and also where they are meaningful. So health equity means everyone should have a fair chance to be healthy regardless of income, background, or where they live. It's not just about choices, it's about conditions. Social and structural factors like poverty, discrimination, and housing shape health more than individual behaviors. When identities like race, gender, and immigration status intersect, the effects can compound. In Canada, despite universal health care, many groups, especially Indigenous, immigrant, and racialized communities, still face persistent inequities. When we talk about health equity, we're not speaking in the abstract. We're talking about the real people who live in this region. So let's take a moment to ground ourselves in the local context. Southeastern Ontario is home to just under 600,000 residents. The population here is aging. The average age is about 45 years. And there are a few key demographic characteristics that really shape the equity landscape here. As you can see over here, each of these statistics points to broader social conditions that influence people's ability to live healthy lives. And the reality is that these challenges aren't experienced equally across the population. Here's a quick overview of the data and methods behind the equity profile. I drew from three main data sources, the SHED itself, the Canadian Community Health Survey, and the 2021 census. Together, these provide a mix of population level and regionally stratified data. I focus on 6 health indicators that you see over here, and they are all relevant to public health and closely tied to social determinants. And these are the equity stratifiers that I chose. And that's what helped guide what I chose to highlight in the health equity profile. To assess inequities, I use 2 key measures: rate ratio, which shows relative differences, how much more or less common an outcome is between groups, and rate difference, which shows absolute gaps, how many cases could be avoided if that gap didn't exist. Using both help us understand not just where gaps exist, but how big they are, and that's essential for guiding action and planning upstream interventions. So now I'm going to move into the actual topics and stratifiers I focused on, starting with general health by income. In the Southeast region, fewer people with lower income report very good or excellent health compared to those with higher incomes. And that's not unique to us, but the gap is larger here. You can see that in the numbers: a 25-point gap in our region, 13 points in Ontario overall. Income affects access to resources, housing, food, stress, and ultimately health, so that the fact that this gap is wider here in our region suggests we need to pay close attention to how income-based inequities are playing out in our community. Here's another example that really stood out, this time looking at mental health by income. In the Southeast, fewer lower income residents report very good or excellent mental health compared to higher income groups, and the gap is stark. We're seeing 22% difference here in Southeast compared to just under 9% in Ontario overall. So once again, while income affects mental health everywhere, the impact appears more severe in Southeast region. The next one looks at premature mortality, deaths before age 75. In the Southeast region, people in more materially deprived areas die at much higher rate than those in less deprived areas, and the gap is dramatic, as you can see here, 160 and 62 in Ontario overall. And this really speaks to how place-based inequities, things like housing, employment, and income shape how things like housing, income, and employment shape health long before people even enter the healthcare system. So now I'm going to shift to a health behavior now, smoking, and how it's shaped by both income and gender in Southeastern Ontario. In the Southeast, we see that people in the lower income smoke more than those with higher income. But when we zoom in on the females, the gap becomes even more pronounced. Lower income women have smoking rates that are more than double those of higher income women. And this difference is statistically significant, meaning it really reflects something systematic and not random. It is a strong example, and why equity work needs to look at intersection, not just one variable at a time. Here we're looking at alcohol-related emergency department visit in Southeastern Ontario, broken down by material deprivation and gender. And we see higher ED visits rates in more deprived areas for both males and females. But the gap is much bigger for males. This is the last example I'll share today. It focuses on physical activity among women in the Southeast region, specifically comparing immigrant and Canadian-born groups. The data shows that immigrant women are significantly less likely to meet physical activity guidelines, and the difference is statistically significant. No similar gap was found among men, which again highlights the importance of looking at how different social identities intersect. Like other examples today, it reminds us that inequities aren't one size fits all. They show up differently across groups and require targeted responses. So what do these patterns tell us overall? First, that many health gaps, like in general health, mental health, premature mortality, are wider in the Southeast region than elsewhere. Second, income and material deprivation show up again and again as key drivers of poor health. And finally, when factors like gender and immigration status intersect, risks can multiply, especially for immigrant women. So how can public health respond? For income, we need to prioritize low-income communities, expand mental health access, and advocate for policies like housing and childcare. Under education, we can boost health literacy, support adult learning, and invest early in schools. When it comes to material deprivation, the key is meeting people where they are through mobile services, safer neighborhoods, and systematic partnership. And finally, for immigration status, tailoring program, translating resources, and building inclusive spaces can make a big difference. SHED is a very powerful tool. It clearly highlights inequities and supports internal planning through visual and disaggregated data, but it has limitation. It lacked race-based data. It's not very easily accessible to the public, and it really doesn't offer guidance on how to act on the findings. So it's a great starting point, but not like the full picture. The project helped me put public health theory into practice using real data to explore concepts like social determinants and intersectionality. And I developed key skills working with data, translating it into stories, and applying systematic thinking. It also reinforced that measuring inequities isn't enough and we need action. This experience really confirmed my passion for equity-driven work and for staying rooted in the space where data meets community. That brings me to the end of my presentation. Thank you so much for listening, and I'm happy to take any questions.